Scratching, is that okay? Does that sound okay in the back? No, sounds bad, eh? Really bad. Find someone.
It's not going to get better than that.
It's not going to get better?
I say we do
Scrap
how
it?
we always do it.
Okay, it's going to get loud in here. Here we go. You can hear me good now? Excellent. Okay, let's do it. Okay, welcome everybody. Thank you so much for coming out tonight. I really appreciate it. I know your time is valuable. You have a lot of things going on, I'm sure. We're really excited to show you our presentation tonight. So for those of you who don't know me, I'm Mark Stevens. I've been the ITero specialist for BC for Align Technologies for the last 6 years. And I can tell you in that time, I've really seen a transformation in this digital space. And I'm genuinely excited every day to get up and work with all of you who own ITero and to go out and spread the word about it. It's just amazing what digital dentistry has changed over the last few years. When I just started out a few years ago, it was really all about just replacing that impression material. It was the very basic need for that scanner. Now what it's become is I talk to offices every single day who tell me, I talk to offices at this lecture right now that tell me that it's the most important piece of equipment they have in their practice. It absolutely transforms the way your efficiency works in your chair, the predictability and accuracy of your restorative work. It changes the way that you communicate with patients, the way that treatment acceptance is altered as well as just viewed in that patient's eyes. It's a marketing tool for those new incoming patients and for those loyal patients you've had for a long time. It's just an absolutely incredible, diverse tool. So we can't wait to share a few new updates with you, some of the new things we've added. For those of you who don't have a scanner, we're going to show you an introduction of what you're missing out on. Okay? So what we're going to be going over tonight is kind of a walkthrough. We're not just going to show you a product and that's it. We're going to walk through integration of that product, how to use it. We have a couple specialists with us here to help us out with that. So we're going to be starting off with our very own Natalie. Most of you know her already. She's absolutely incredible asset that came to this company a few years ago. We could not live without her. She's incredible. Natalie comes with 35 years of hygiene experience, so she has been in the chair. She's worked with the device in clinic, and she's seen the transformation of her conversations with patients, right? Those hygiene appointments, those recall exams, having a conversation and understanding what is being explained to them. So she's going to talk a little bit about some of the apps and features that she uses on a day-to-day basis and how you can really exploit the most out of that product, that feature, so that you can get the most bang for your buck out of your investment with that scanner. Then we're going to move on to myself. I'm going to talk a little bit about the product itself. I'm more the product specialist. Any technical question you have on that, please let me know and I'm happy to help you out with that. I'm also going to try to contain my excitement as I show you some of the new features that we have just come out with, as well as new stuff that's down the road that I'm not even sure I'm authorized to talk about, but I'm just so excited. I'm going to show you a sneak peek of some of the new things we have coming. Then we're going to bring that all together. We're going to take the theory of the apps and the features and the products, and we're going to have Dr. Lovedeep Randhawa, a titan of digital dentistry, showing us exactly how you can use that in having that better diagnostic capabilities and having that increased standard of care in your practice, and ultimately that better patient communication, which leads to that standard of care, that treatment acceptance, everything. Right? She's going to talk about that in some detail. And then we're going to have James Neuber, RDT, full mouth digital specialist from Ocean Ceramics. He's going to talk to us all about the lab side of things and how he sees on a regular basis the change from analog to digital and how that has affected many of his clients and the predictability and accuracy and confidence that he has in digital, and where you can go from there, what you can do once you have that digital file, and how you can manipulate that in many different ways. So we're really going to get the full spread here today. I'm really excited about it. So without further ado, I think, one more thing actually. Last minute change here. We are going to be recording this. My good friend here, Mark Wagner, from Dentist on Demand, has offered to come, and we're shooting a little video right now. We're recording this. He's got these very fancy boom mics. I don't know how he does what he does, but he's got some great stuff going on. If you're not familiar with Dentist on Demand, it's pretty cool online CE. I really don't know enough to speak about it, but I've heard good things out there in the industry. So if you want to access the photo, share it, or not the photo, the lecture, or share it at any point afterwards, Mark will, I'm sure, share that link with us so that we can access that. Okay? Thank you very much. Natalie.
All right. Well, welcome everybody. So just a little bit of housekeeping before we start. I want to make sure if you want to get your seat, you have to make sure that you sign the sign-in sheet that's at the table at the front. So if you haven't done it yet, make sure you do it on your way out. I want to thank everybody for being here. September's upon us. Back to school is over. Tomorrow's the last day of summer. The dental offices are about to be full with crazy patients trying to maximize their insurance last minute. And Christmas is in 96 days, but that's a whole other issue. But tonight is all about being here. I want to thank you for being here. Mark, you know, he said it well. I've been a dental hygienist for 35 years. So what I want to share with you, when I talk about the features of the ITero, it really comes truly from a more clinical side. I want to show you how to use it in a way that this is not for the purpose of just selling Invisalign. At the contrary, we want to show you how this should be your standard of care for all of your patients, capture that digital record, be able to identify if they're at risk of breaking their teeth or breaking their dentistry. Could it explain why there's a perio pocket? Could it help you identify your pre-restorative? Could that be the reason why there's more recession? So it truly is a shift in the mindset. You're not taking a scan with the purpose of selling Invisalign. You're taking a scan to better educate your patients, keep track of changes over time, catch things early, help the patient, I would even say predict if the patient is at risk of chipping and breaking their teeth or their dentistry. So it really comes from a more of a clinical side. Some of you may know me because I was the adoption specialist for BC for the last 4 years, but I am now the Invisalign Territory Manager for Surrey Delta. So if there are any doctors in the room from Surrey Delta, please, please, please come and see me and introduce yourselves, because I will be hopefully seeing you very soon in your offices. All right, so we're going to talk about why digital. I'll talk about the engagement tools. Mark went over this, the family of scanners, new features, newer features, and some hot off the press features that haven't even been launched yet. And then we'll talk about the new Align Oral Health Suite and lab communication. But really, it's a little bit of everything for everybody, whether you don't have an ITero yet or you're not digital yet, or whether you have an ITero but you're not fully maximizing it, or whether you have the latest technology. We're going to show you that there is more that's coming. So it really is a little bit of everything for everyone. I think you would agree the world has become digital, and so have our dental offices. And I truly believe that digital scans are going to become the standard of care. Just like digital x-rays, this is going to be the norm. So if you don't have a digital scanner yet, we don't want you to be stuck in the Stone Age. See how I did a little play of words here? We don't want you to be behind the times. We want you to be progressive. We want you to be that doctor that's, relevant, progressive, ahead of the curve, that has all the latest technology, that can educate your patient. You can catch things early, you can keep track of changes over time. That is what patients want. They want the same thing in their everyday world as they expect in a dental offices. So I'm going to go over some patient engagement tools. I'm not going to go in very deep detail because we'd all have to take a room at the Sandman tonight. But I'm going to kind of cruise over the different options and let you know what is possible. If you've ever heard me speak before, you know how passionate I am about the occlusogram or the bite map. To me, this is the foundation. To me, as a clinician, as a hygienist, this, I would argue, is more important to me than my perio chart, than my photos, than my intraoral photos. Because this bite map, if you know how to look and analyze it, you can tell the patient or predict if the patient is at risk of chipping their teeth, breaking their dentistry, like I said, perio pockets, recession. It can help you catch things early, educate them, and let the patient make that educated decision. I'm going to show you what the power of one scan can do for the life of a patient and how it can change your practice. This is an example of how one scan changed a patient's life. Patient comes in, we scan because that's the standard of care. The patient walks into a dental office. The doctor says, do you have any concerns? Not really. Well, I wish my teeth were whiter. Okay, that's easy to do. Now, what about all this amount of wear? You're a pretty young guy to have this amount of wear on your front teeth. Anybody ever mentioned that to you? Oh, I used to bite my nails. Okay. What about the missing tooth on the top? Has anybody ever explained to you that if you have a missing tooth, that the opposing tooth can start over-erupting? Did anybody ever explain to you that by having a missing tooth, the upper tooth could drift forward? With the power of just one scan, the doctor was able to use the bite map and show the patient that because of the red contacts, red means zero clearance, because the front teeth are hitting, I'm concerned that your bite is the cause of all the wear and the chipping on your front teeth. And now with this scan, now of course if this was a true scanner, I could flip it around and turn it around, but you can now show the patient from a lateral view how the lower tooth is over-erupting. You can now show the patient how the tooth has mesialized. So why we're still using a mirror and still using a mouth mirror to show the patient, turn the patient upside down to try and show them a broken tooth at the back, that to me is a little bit archaic when you can just pull up a scan, turn it around, blow it up, show the upper, show the bleeding, the tartar, the stain, the chip, the recession. That is the power of the scan. So I don't do any OHI in a patient's mouth. I only use my visuals. I show tartar, stain, chipping, wearing from the monitor. After one conversation, one scan, the patient proceeded with ortho to put the teeth in proper alignment, replaced the missing tooth with an implant, went ahead with 10 crowns on the upper anterior teeth, spent in the vicinity of $30,000, $35,000, and that came from one scan, one conversation. Not to say that every single patient will accept that amount of treatment, but it shows you how you can show the patient the benefits of proper tooth alignment, benefits of restorative. And that patient happens to be in the room this evening. That would be Mark. The doctor is also in the room because it was Dr. Randhawa who did the first scan for the first time and educated Mark. And we have James because his 10 crowns came from Ocean Ceramic. So it's kind of funny that this kind of comes full circle this evening, and this was not planned. I swear to God, I picked one scan and I thought, okay, this is crazy. Everybody and everything is coming together. So that is how you can use it, Kuzabrat. So now you can see the before and after, you can see Mark before and after, and you can also see the difference in the bite.
Is that his high school picture?
Yes, Mark was 12, and now he's 18. So now you can see the bite before, how there's a lot of hitting and colliding of the front teeth, and after proper tooth alignment, less risk of chipping, breaking the teeth, or the beautiful dentistry that was restored. So that to me is a foundation, is how I speak to my patients, is how I educate my patients. That is on my monitor for every single patient, for every single recall. Now, the time lapse is probably my second favorite. The time lapse allows you to see if there are any changes over time. Again, I can argue all day, every day. There is no way for me to remember every little chip, every little wear facet, every little micron of recession, every little wear on every tooth for all of my patients. But the scanner can do that. So I'm going to play a little video. So the idea of taking a scan is that you would take it, call it every year, year and a half, and it allows you to pick 2 scans to overlay them, and it will measure movement, recession, and wear for you. So when it's time for the Mr. Gingerbal's annual scan, you can see the patient has 3 scans on file. You're going to pick the earliest and the latest, click the compare button, and now it starts analyzing. We don't have anything in our tool belt right now to measure wear. There's no way for me to measure if a tooth was 13 millimeters high and now it's 11. There's no way for me to have, even with the best SLR camera, even if you took a series of photos, you wouldn't be able to pick up these small, minute differences. But look at here. Look at the before and the after. Look at the wear facets. Let's look on these two. Look at the before, the after. Look at the wear facets. Move the model around, grab the magnifying glass. Take a look. Look at the wear facets. I think everybody would agree that there's no way for us to see or notice or keep track of that. So now we can have a conversation and say, remember when we talked about your bite last year or 2 years ago? What concerns me is that with that amount of wear, if we don't address the bite, this is going to get worse. So now it's up to the patient to make an informed decision. Do we keep monitoring or do we address the bite? And notice how I say we need to address the bite. I never say you need Invisalign. We need to address the bite. And then when the doctor comes in, then you can do the handoff. But look at the recession. Look at the before and after. I don't know if there are any other hygienists in the room, but I spent 30 years explaining a perio chart. So what do the patients say when you say, oh, you have a 323, 222, 141, 222, 323? They have no clue what we're talking about. But if you show them the recession, they're more inclined to pay attention because it's a visual. They want to see the change, whereas a number means absolutely nothing to them. So that is the time lapse. But again, without the baseline, you can't compare. Near technology. If you haven't seen it yet, it stands for near infrared imaging. It's basically doing a caries exam without any radiation. So straight from your original scan, you don't have to take an additional scan, with the same scan that you took as a baseline, you can now do a caries exam by just grabbing the magnifying glass and looking for decay from an occlusal view. So we've had it around long enough to have some really good data. It's been proven that we're finding 56% more decay using the near technology in conjunction with your bite wings. It doesn't replace it, in conjunction with. I can now tell you that I've had multiple doctors that have told me that they have found more decay using the technology than without. Because the beauty of the NIRI is that unlike a bite wing, if you have an overlap or a bad open contact, or no open contact at all, you could easily miss a cavity between 2 teeth. But because NIRI looks from the occlusal view, it will find an interproximal cavity even when the teeth are overlapping. You can use this on pregnant women safely, on patients undergoing chemo safely. One of my favorite ways that I used this was with my little children, my 4, 5, 6-year-olds, that either they gagged on the sensor, threw up on the sensor, moved with the sensor. I started scanning their occlusals and we started doing caries exam right from the screen. When you say to a little kid, let's take a video of your teeth and let's play a video game, they would much prefer do that than put a big heavy lead apron on and say, don't move, and you run away. That is a scary experience for a child. But to do it with the ITero, it's a great way to find and identify, or even confirm if, for example, you had a watch. I don't know what we're watching, but if you have a watch and you're not sure if you should leave or treat, you could easily use the NIRI technology to confirm if in fact, and I could tell you that almost always our watches turned into full-blown cavities. So absolutely great tool, and again, many of my doctors have attested, and It has been a phenomenal tool, and they have found more decay. The other nice thing is that you have a built-in intraoral camera. Same scan, you're not taking multiple scans, but you now have a built-in intraoral camera that you just have to put over the tooth. So long gone are the intraoral cameras that you have to take a picture. Yes.
Question. Can you send these images off to insurance for approval?
Yes, you read my mind. So instead of taking a whole series of pictures with your SLR and then a whole series of pictures with your intraoral camera, with that same one scan, you have everything built in. When you scan, the scanner is taking an intraoral picture for you every 1/8 of a second. So if you needed a photo for a pre-D, if you needed a photo to send to a specialist, if you needed a photo just to keep for your own records, you can send that photo. And yes, you can use that photo to submit for pre-D. Yes.
Will they accept the Neary technology to support approval?
No. So that's why we said, we call it, it's an aid in caries detection in conjunction with your bite wings, because your bite wing is still your legal document.
Okay.
It is purely an aid. And it also looks at a different angle, right? The bite wing, I always say the bite wing looks at the vertical dimension, whereas the Neary is the width. So it doesn't replace, but it supplements for sure. So now instead of taking a whole series of intraoral photos that you have to crop and label, and God forbid, I've done this so many times, took 4 or 5 pictures, forgot to label them, and now I'm trying to guess what tooth is that. Is that a 1/6? Is that a 4/7? I have no idea. Whereas if you use the magnifying glass, you see exactly that that tooth is right here. So it's also a better visual for your patients. So built-in intraoral cameras. The Invisalign Practice app, formerly called the Invisalign Photo Uploader. If you haven't downloaded this app, and if you're not using it yet, I highly encourage you to do it as soon as possible. I would encourage you to have a device, call it a office-dedicated phone, iPod, iPad, it doesn't matter. You download the Invisalign Practice app. It's encrypted, it's safe, it streamlines everything. But the goal of this app is to take this middle picture right here. You can still take your extraorals. You can still take all of your intraorals. But this new picture right in the middle, this picture here, allows you to do in-face visualization in your ClinCheck. So now you can have your ClinCheck and see the result in the patient's face. You can use that same photo, which I'm going to talk about the IOSIM Pro in a moment, but it's also the same photo that's going to help you with your Smile Architect, which we're going to talk about. So that one photo has multiple purposes. So we highly encourage you to start making that also standard, where you capture that single image, what we call the wide smile, and it's going to help you, and we'll show you the apps coming up. So here is one of them. You can now take a selfie, take a scan, merge, and you can now see the patient smile in their face. Unlike the classic outcome simulator where you would have a before and an after, kind of that cartoon rendition, now you have it live. It's still an algorithm, but I would say that the algorithm is much superior than the original one. If you're familiar with the classic outcome simulator, if there was a tooth missing, you had to know how to manipulate the teeth and keep the space open, because if not, the algorithm would just mesialize everything. Now with the IOSIM Pro, we'll actually plug in a Pontic for you. So just easier, more intuitive, more effective all around. And we have some stats here where, here are numbers. Here's the difference between case acceptance if you did not have a scanner at all. This is if you had a scanner without using any of the additional apps. 20% increase if you add the Outcome Simulator Classic, but an increase of an additional 30% when you use the IOSIM Pro, which is the in-face visualization. For the simple reason that when the patients see their smile in real time, real life, that is a true closer. That is a game changer. So if you're ever, wondering what you can do differently, how can you convert, how can you change, what can you do in your consults, having that in-face visualization has been a huge, huge game changer for our doctors. And that is only available on the 5D Plus series. Look at the difference in the imaging. We call this texture mapping. Just like iPhones get better and better and better, scanners get better and better and better, and the imaging has improved dramatically. You no longer need to submit any intraoral photos for your Invisalign cases anymore, because we simply upload the scan and split it in 5 different angles. So we've eliminated the mirror taking. So remember the mirrors, the retractors, the gagging the patients? You don't need to submit. You may want photos for your own records, for treatment planning, but you do not need to submit them. You don't need to upload, crop, label, and do the drag and drop thing. And then you have an ITero scan report. So if you wanted to do a follow-up, if you had a patient who was on the fence, you wanted to send a photo of a broken tooth, or what their smile could look like, or a picture of a cavity, you can now simply, 4 clicks, you can simply go orders, patient, ITero scan report, print. You can populate as many photos or as few photos as you like. You can type in a nice little message at the bottom, and you can send that on the patient's phone. So lots of ways to do follow-ups, to keep the patients engaged and on top of things. Now, this is proprietary to ITero. I am shocked at how few offices are aware that you can bookmark myitero.com on every computer in every room in every op and have access to scans from everywhere. Even though you may only have 1 scanner in your office, you could have the treatment coordinator accessing a scan from the consult room. You could have a hygienist accessing the scan to do the education. You could have the doctor using the scanner to do a crown. And you could have the receptionist at the front pulling up a photo to send for pre-D. So I encourage you, I'm going to say it's the least known feature, yet I think it's just so impactful. So make sure you bookmark myitero.com on every single computer in every single room, so that occlusogram can be up on monitor in front of each patient for every hygiene appointment or every restorative appointment. And now I'm going to pass it over to Mark, who's going to talk about some of our newer scanners and some of those features.
Before I get into that, let me publicly thank Dr. Lovedeep Randhawa, James, and David at Ocean. I couldn't be happier with my new teeth. Absolutely love them. It's completely changed my life. And as we talked about, I'm really, truly passionate about the product that I sell. It's not just another job for me, because it personally affected my life so much. And it's not that other doctors, I've lived in 4 provinces, I've moved a bit, I went to 5 high schools, and I've been to 10 different dentists in my life. You think none of them mentioned I'm missing a tooth, or that my teeth are burning, or the yellowing, or anything's going on? Just ask my wife after we've been in an argument. It's not just what you say, it's how you say it, right? It makes a big difference.
My white teeth have never gotten yellow.
Right, so to have the best tool to communicate really goes a long way. Something I wanted to comment on as well. When we were talking about the intraoral photos, one thing too that's really neat is those photos automatically go to the lab. When you scan those pictures every 1/8 of a second that they are, when you scan and send it to the lab, they automatically go to the lab. So if they're a little bit unsure on that undercut, on that is that the margin line, is that the cord, it's a little bit unclear, they can access the actual photos. It's gone a long way, and that texture mapping, that better clarity is helping with those restorative outcomes as well. Okay, so I just wanted to mention those things quick. Family of scanners, I'm not going to go over them all, but we now have 9 versions of the ITero scanner. Okay, it's a lot, it's overwhelming. but what's nice is we have something to meet every need. If you're looking more cost effective, we have that. If you're looking for the most advanced technology, we have that. If you're looking for something in the middle, we have that as well. We're going to mainly talk about the most advanced technology today. It's the 5D Plus, which is what's the cards is up here. Why I'm most passionate about the 5D Plus over anything else, they will all scan, they will all get a crown to fit, things like that. But it's the new software that we've been coming out with is really setting us apart from anything else out there in the industry, and it's really having an impact on that standard of care for our practice. So this new scanner here, we talked about it's now integrated in an intraoral camera and near-ear caries detection, right? More records is better dentistry. If you have more records, you can diagnose better and you can treat your patient better. Okay, so that's important. The scanner is 50% faster and 20% less in that spinning in the wheel while you're loading from one app to the other. Okay, 50% better? Okay, it's fast, cool. What's important about that number is, on average, the element 1, element 2 would take anywhere from 4 to 6 minutes to scan. Okay, the new system takes anywhere from typically between 90 and 120 seconds. Okay, the difference isn't just how fast that is you don't always have 6 minutes in the chair. Right? You're a hygienist, those hygienists in the room, good luck finding 6 minutes, right? 60 seconds, 90 seconds, you can find that. So we've been talking, the story of ITero has been for a long time to, it's drive patient communication and all this, and use it on every exam, use it on every patient, using your consults, but you didn't have the time. Now because of the speed, you're able to fit it into that every single appointment. That's what's important about it. We have the new in-face visualization features and all that. There are two factors in a patient's decision making, right? There's the function and there's the emotional side, okay? Some doctors will focus on the emotional, some doctors will focus on the function more. The good doctors, especially Dr. Randhawa, I've personally lived through, focuses on both. Because you have to understand that the aesthetic, the emotional side of things, is what's ultimately going to get that patient to say yes. But emotional has a limitation to it. If I tell you I can make your hair, skin, teeth, whatever look better for $100, let's do it. 500? Okay. 1,000? Let me think about that. 5,000, 10,000, 20,000? No. You stop. You're like, I don't need to have smoother skin. But if you combine the functional with that, this is a problem. It's going to progress. Right now, it's a relatively easy problem to fix if we get ahead of this. And then combine that with that emotional aspect of bringing in the in-face visualization. This is what you're going to look like. This is what we can do, even the steps beyond Invisalign. This is the restorative digital wax-up we can do for you. Okay, that's smart architect design. So that's what this new system has done for practices. We just recently launched, like 6 weeks ago, this new version of it. So we have the cart version here, very nice presentation tool, rolls around and off nicely. But now it comes available in the laptop. It has the exact same capabilities, same software, same speed, same everything. It's just in a laptop model, okay? What we were able to do is we were able to bring the price down significantly and bring that out so that we can now have the most advanced technology at a marginal increase from our middle of the line technology. Okay? And hopefully everything we're showing you tonight is showing you the reasons why that advanced technology really will pay dividends for your practice. Looking at restorative, ITero has always been a leader in restorative dentistry as well, and we're going to touch on that a little bit later on today. Some things to focus on, though, I want to talk about is we do have over on the side here, we have modeling interpretation department. This is quite unique to us that our scanner system offers that other systems don't. The lab guys will tell you not all scans are created equal. And we're not talking about the statistics of what's more accurate and what's not. It's in the doctor's hand, this scan looks different than that scan. It's tissue control, it's moisture control, it's all of that. If the doctor captured the information, but just overscanned, which is the most common issue in scanning with all systems, we have the ability to, or the lab has the ability to send that on to us. It delays your case by about a day. We'll clean it up and send it back to them so that they can have a nice, beautiful visibility at the margin line or whatever the context or whatever is the discrepancy. Okay? That's a really nice save for you so that you don't have to call that patient back. We also have milled models available. Not as commonly used anymore, but it is nice to have that option. Nowadays, printers have come a long way, so labs that are more digitally inclined, that take the time and to research and then invest in the technology, can do very similar accuracies to the milled models. Okay? The milled models are wonderful, but they take a week to come to the lab, and nowadays everything turns over really fast. It's nice to have that option though, machines go down, maybe you want, a full arch case, you want that little bit better accuracy. Maybe it's a matter of working with a small lab that can't afford the advancements in technology and that printer and everything. We do have these available, okay? Again, just something unique. If you have any other system, a Trios, a PrimeScan, whatever, you're not going to have an option of a milled model. It's whatever printer your lab has, and that's it.
Hey Mark?
Yes.
Just a little side note to that. Those for the docs that really love still PFM and gold, those are the go-to modeling to order from a lab. I think they're still, bar none, the most accurate digital model to work off of for old school techs that are working on a traditional model. The other ones are so hard, the printed ones, they're not the same. They're really hard to work on.
Appreciate
For
that.
the PFM and gold stuff,
Yep.
that's really hard to import.
And I get asked
Metal
about
occlusion, PFM.
Yeah, it's still,
It is a go-to.
it's a go-to still out there, but yeah.
So there you go. When you have ITero, you have options.
Yeah.
Right? You're not limited to what materials you have to use. It's whatever you want, and we can
You
accommodate.
can't get those from another scanning company.
That's right.
You can't. They don't have that.
Thank you for that. Appreciate that. Okay. Last year, I know there sometimes are rumors about ITero doesn't work for restorative. There's many factors. I don't know if James will touch on it, but I have worked with James before, and they will offer a digital assessment to see what went wrong, because there are so many variables in what could have happened. It's really important to work with a lab that's going to be that partner and really understand digital. I'm telling you, I'm not going to throw anyone under the bus, but I have a lot of conversations with a lot of labs, and they truly don't get it. They don't understand what the difference between an STL and a PLY file is. They can't name the big competitive scanner companies, right? They don't know the difference between Sirona in-lab software, 3Shape software, and ExoCAD. And then paying for those upgrades and those dongles, and there's all these extra charges that all these companies come with that not everyone will go for. So it is important who you partner with when you're going into digital. Here's a quick study, just a quick look. Don't want to highlight too much, but I do like to show that ITero is consistently in the middle of the scale for whether you're talking about quadrant or full arch. A lot of scanner companies, even not to name names, I didn't say anything, but they are often called the restorative gold standard and the scanner for restorative and all that. They do not do very well on cross arch. Okay? ITero consistently does well, study after study, in the restorative accuracies. Some new ITero features. Does it start on its own? Wow. Sound.
Introducing. First of its kind. Invisalign Smile Architect software. Groundbreaking innovation in ortho-restorative care, transforming many invasive procedures of the past into patient-centric, minimally invasive treatments of tomorrow by making ortho-restorative treatments an accessible part of your everyday dentistry. Invisalign Smile Architect ortho-restorative treatment planning software combines orthodontic and restorative treatment planning in a single platform for predictable outcomes. Because 45% of prosthodontic procedures benefit from pre-restorative tooth alignment, Invisalign Smile Architect software unlocks practice growth in your existing patient base. Our technologically advanced features are fully integrated within the ClinCheck software, allowing you to address the underlying malocclusion in many of your restorative cases. To help preserve healthy tooth structure, deliver great aesthetics, and promote lasting oral health. Enhanced visual communication helps increase treatment acceptance by making complex plans easy for patients to understand, so you can inspire confidence and deliver outstanding clinical outcomes that create satisfied patients and efficient practice. Invisalign Smile Architect Software, the future of ortho-restorative smile design.
Wow, that's amazing. So we're talking, forget talking about the scanner for a second. When you work with ITero, when you're working with Invisalign, you're choosing to work with Align Technology. Align Technology is an impressive company. This smile architecture we came out with 3 years ago, we spent $500 million buying ExoCAD. ExoCAD is a CAD/CAM design company. For 3 years, my company hasn't said a peep about what we're doing with it. Finally, we launched this just like days before PDC, and this is available to you in your ClinCheck software right now. You can go in, do full smile design software mockups. You can design, adjust, and then it's an open STL file that you can send on to your lab. You do the macro design, they do the micro design, they can fabricate it and send it back to you, right? This is an incredible service that they're offering at no cost to you. I can tell you, like, digital smile design, I'll say, I've used it, digital smile design is better. Ours is probably 85% of the way there, but it costs between $1,000 and $1,500 per case. It's a significant increase to your patient, right? This is available to you free. You have full control over it. You can grab individual teeth. You can change the shape, the size. You can adjust the lip lines. You can mirror one side to the other. You can change the opacity. You can change the whiteness of it. You name it, you can basically do it. And like I said, I really like it's an open file.
Mark, I just wanted to add to the DSD thing. With the DSD, it is planning where you want your restorative to be. With this, it gives you the option when you're setting up your ClinCheck, you can set up your ClinCheck for minimally invasive dentistry. So let's just say you want to plan veneers. You don't want to remove too much tooth structure. The ClinCheck end will not look good because it is not orthodontically, like you don't want, oh my God, my old child is too little, this and that. But the thing is, you know where you want to end up. And this gives you that. This gives you that final outcome. It also has the map where it tells you how much tooth you're reducing. You can change the position of the tooth in your ClinCheck. So basically it is, you're doing better orthodontics, you're doing better restorative. You are seeing the end where the gums are going to be, where your occlusion is going to be, even before you start moving the teeth within this line. So I just wanted to add, I don't think there's a comparison between DSD and Invisalign Smile Architect. I think they're totally two different things. Me being an ortho-restorative dentist, I would do this over DSD. And I'm not saying it because I'm paid by Align to say that, but that's what I would do.
I appreciate that. Yeah, thank you very much. Yeah, I do like that it's this comprehensive look at dentistry now. It's not just let's focus on the Invisalign and then we'll see what we can do later. It's let's plan this whole thing out right now. Really incredible. So how does it work? You use your iPhone app, Invisalign Practice app. You just need that middle image, that wide smile, get them to smile as big as possible. If you have crowded on the lower, you can get them to open their mouth and their smile. You can have them smile like that and it'll show that transformation. You take your scan, and then when you're filling in your ClinCheck, there'll be 4 boxes on one of those first pages where you're requesting comprehensive or light or whatever Invisalign case you want. At the end, there's one that says Smart Architect. You click on that and we will design for you and send it to you, and then you have full power to adjust it. Okay? So here it is again quickly. You take the picture on the phone, you have it on the ITero, and then it opens in your ClinCheck. It does not open on your ITero, it opens in your ClinCheck. Okay? It does take a day or two for this to process through. This is not going to be immediate. Not that you would have the chairside time to sit there with the patient and design a whole smile right there, right? What it also gives you is it'll give you a tooth mass analysis. So now, again, comprehensive dentistry, you can make that informed decision. Patient comes in today, says like, oh, okay, got a big bonus check. Let's do veneers. Let's pump the brakes. You have 80% open, right? Let's calm down for a second, right? Here are the options. We could see if we do it now, and the scale will tell you the millimeters, but you didn't need to adjust this much right now. If we intruded your teeth first, and it'll give you the amount of trays that's required in that, okay, there's 9 trays, 9 weeks, whatever the case may be, 3 months, 4 months, we can intrude those teeth, and now we have to reduce only that much. Keeping natural dentition is always favorable for that patient, right? So that's all analyzed through AI automatically. Upcoming features. So that's what's out now. Let's take a look at what's upcoming. Impressive, right? It looks really nice. Seamless AI. I had a talk with Dr. Megan at the beginning of this lecture talking about how, yeah, we have some fees with ITero, we have some costs with Invisalign. Nobody likes it. I don't like my Disney Plus subscription, right? It's like $7 or whatever it is, right? But you see what you get when you're with Align. This is not cheap to do. This is a huge undertaking. That seamless AI is really incredible. So again, what we like about the ITero is that it's not just a product. It's elevating your whole practice. Having one scanner in your practice, you take your scan, you send it away to ClinCheck, you're doing smile design, you're doing AI, visual mock-ups, video mock-ups. This elevates your everyday practice to cosmetic dental office. Like those downtown Vancouver, come in and we'll give you the full treatment. There's the vaporizer with the scents in the air and all this. This elevates the practice significantly. It really wows your patients, and you're able to provide that better level of care. We also have coming some advancements on the lab side of things, which won't affect you directly, but just so that you know what your lab's able to enjoy. Because your scanner is taking those ITero photos and caries detection simultaneously, when they open up your STL file in exocad, they can take their mouse, just drag it around the image anywhere they want, and these images will follow them around. So they will see the ITero photos as well as the caries detection. We are in beta testing right now. We don't have any studies or stats to support it yet, but using the caries detection to help you with those subgingival margins, to help with margin lines underneath a little saliva bubble or moisture or whatever the case may be, right? Really elevating things so that it makes it easier and easier for your predictable dentistry. We also are going to allow the lab to be able to design as they do right now. Nothing new there. They're designing that single unit crown. We're not talking about full smile design software now, just doing that single unit, and they can send it back to your MyITero login. It'll go right there on your MyITero cloud screen, and you can improve it, you can adjust it, you can just have a conversation with your lab. I have been in dental for 12 years. I can't tell you how many lectures I've attended where they talk about the importance of your lab and your doctor should be best friends, should be talking 12 times a day. Yeah. This is connecting you perfectly. There's no, let me send you a screenshot, let me try to explain it to you. This is what we're doing. We're working together live on this, right? Really, really incredible. The next thing, I don't even have a slide for it because it's so new, but I'm just going to spill the beans a little bit here, is we, again, invested a lot of money in a certain company to have AI diagnostics of bite wings, x-rays, things like that. So you will be able to load in your CBCT, your bite wing, whatever the case may be, into our software, and the AI will determine where there are carious lesions, where there are fractures, where there are a whole slew of things. Really incredible. Again, Align technology is moving that practice forward. as a whole. We're no longer an ortho company. We're not a plastics company. We are a technology, and we are a comprehensive dentistry company. Dr. Lovedeep Randhawa, please.
Disclaimer, I really did not know that Natalie was going to show that case that was going to have Mark and me and Ocean Ceramics in there. I think it's like a reunion of
I know.
right? Like, no clue. But anyways, thank you. Sorry, I have to put my glasses on. Down. Okay. Okay, perfect. A little bit about me. I graduated University of British Columbia Dental School in 2004. I've been practicing in Delta Surrey area since then. I built 2 practices, ended up selling one just because I felt like it, and now I run my practice in Surrey. We are a small 4-chair family practice near Walmart, but the beauty of the practice is it's not how big it is or how small it is or where it is. It is about how we work as a team with our patients. You know, as Mark said, it's about the emotional aspect, it is about the functional aspect. Getting to know your patient, getting to know what their needs are, and then explaining it to them. I feel an educated patient is the best patient you can have. What do we do as dentists? We present cases. We get the cases accepted. And then we plan that treatment, right? How do you want to do that? You want to do it more efficiently, more predictably, right? And that can be done digitally. As I said, I have a small little practice. I could not invest in PrimeScan and Trios for one thing, and ITero for Invisalign. I invested in ITero because it did everything for me. So, anyways, these 2 have given you all the information, and I can go over, but I need a lot of time to talk about Invisalign and to talk about restorative, but I have, of course, like lectures for that as well, and you're welcome to come in and, tell me, share my work.
This is the time to put in the plug. If you want to know more about partial denture scanning, Dr. Randhawa is doing a presentation on Monday night. It's in Vancouver, but it's a lovely venue if you would like to join us. So on your tables.
And I do ones for in-office milling, I do for comprehensive dentistry, everything, but this is the one that we have coming up now. Okay, I'm really excited about this. Align Oral Health Suit. So in spring, I got contacted by Align Technologies to be part of beta testing on limited market release of Align Oral Health Suit. It was very, very exciting because we were going to be only very few dentists in the world that were going to have access to it, use it every single day in our practices, have feedback meetings with ITero and Align, and it was really, really exciting to do this. It wasn't called Align Oral Health Suit at that time, it was called something else. So I'm just going to go over a few of the slides to show you how it started, and then I'm going to show you how it looks like now and how it works in my practice. Oh, sorry. I have the glasses and I'm still doing this. Okay, so it used to be called 360, then it was called 360 Hub, and now it's called Align Oral Health Suit, and it's a mouthful, but it's actually really interesting. It's a comprehensive oral health assessment digital suite. So in the past, what we did is your hygienist or your assistant scanned your spec exam, your emergency exam, recall patient, new patient, Invisalign consult, whatever, and you walked in and you pressed on the viewer button, and then now you're trying to see when you're overhearing your assistant fighting with the other assistant as to who dropped the digital x-ray sensor, and your receptionist fighting with a patient that doesn't want to pay their copay while you're doing a new patient consult, and in your brain you're going, oh my God, what am I supposed to talk about? Well, there's a clusogram, there's time lapse, and we did talk about all that. But the beauty of this is you walk in, your hygienist or your team member has done the scan, and this is what shows up on the ITero 5D Plus screen. This is that patient's 3D scan, intraoral scan. So when you walk in, this is what you have. I call it my teleprompter. I can have all my staff fighting, and the patient's running out of the office, but I don't get distracted because I have my teleprompter right there. So now I know I'm not going to miss anything. I can educate my patients. So, good.
God, I keep pressing the wrong button. Okay, this is the next one. I'm sure because we went from here. So we're going to talk about caries, we're going to talk about gums, we're going to talk about tooth wear, alignment, and explorer. So caries. Now, there are default settings on this, but you can change it. So when you go to caries, you normally show in true color, but you can go to stone model, which doesn't make sense. But anyways, I just wanted to mention it. There's NIRI and there is the intraoral camera right there. And as Natalie has already explained to you, you can use that NIRI technology to diagnose not only a diagnostic aid for interproximal caries, especially in those crowded areas, mesials of your first bicuspids, that's a mess. It's so hard to get that contact open. This really helps there. I don't even know how many more, every 3, 4, 4, 4, 1, 4, 2 for mesials I diagnose now with this. But the other thing is also the intraoral camera. If you have a patient with a very large composite restoration and you're telling the patient, you need a crown on this, they don't know. They don't understand it. It's not bothering me. I'm chewing fine. I'm functioning. It's not affecting the quality of my life. When you use that intraoral camera and you hover over something, let's just assume that this entire thing is composite. Do you think they're not going to look at it and they're not going to say, oh my God, what's going on? Or a huge amalgam that shows leakage and discoloration on the tooth. Do you think the patient's not going to be interested to find out what's going on there? So this is really, really effective because when I start with this, I'll say, okay, we're going to start from the upper right side and we go from every single tooth. We talk about crack lines, graze lines, everything that I can see in NIRI and the intraoral camera. And then what I do is, just to make sure the patient is also taking time to digest it, I will actually make notes. So what you can do is, you can take a screenshot right there, and a little thing will appear here. It takes a couple of seconds, then it will come up on the main screen. There are buttons that things on top that have colors. You can draw things, you can write text, and you can write for upper right molar or 1/6, large composite, failing composite, advised crown. You are making notes, and those become part of your ITero scan report later on. But the patient is also seeing that this is happening, which you can use to communicate with your patients. You can use that ITero scan report to go to your front desk, who will attach it to your patient's chart. It forms kind of your patient record, informed consent, whatever you might want to call it, as well as it'll help in your insurance communication. Okay, then we go to gums. Very clear. Patients understand caries, gum, tooth wear. These terms are very, very easy to follow, and as it's highlighted, they know what we're going to talk about next. You can use the intraoral camera. You can go through recession areas, abfractions, frication to explain. Try explaining frication to a patient using images or drawing. This really explains patients what a frication is. So here, and the other thing is when I'm talking about caries, I don't talk about anything else other than caries, failing restorations. That's it. When I'm talking about gingiva, I don't talk about anything else other than periodontal health. Now you go to tooth wear. This is our favorite occlusogram where it comes into play. My team really loves occlusogram. So this, you have two options. You can go either one arch at a time or two arches set next to each other and talk about both arches at the same time. Now you can go however you want to explain to the patient why they have rare facets, why they have crack lines, why they have so much sensitivity on 1/7, whatever's going on. This is your way to talk about premature contacts, whatever you want to talk about that you saw in the patient's mouth and you see it here. This is the way to communicate with them because they understand you're talking about tooth wear here. Then you go to alignment. This is where I start talking about malocclusion. This is where I'll draw my class 1 molar, class 1 canine. You are forward, you are backwards, spacing, crowding, all those things. And then I go to Explorer. The beauty about Explorer is you can still use all those features. This is my summary page where I go, okay, remember we talked about this. Do you have any questions? Here you can go back. You can use your NIRI here. You can use your magnification mirror here. You can use your occlusogram. You can use your time lapse. When I show you later on how time lapse works on this, it's so exciting. I still remember when Mark walks in one day and, oh my God, Mark, he goes, what happened? Oh my God, have you seen the new time lapse? I'm just crazy like that. I just like it. Oh, and this is mine and Mark's favorite, right?
Yes,
This
love
is
that.
our favorite. You're gonna love it when you see it.
Should we go live?
Actually, you know what? Mark was suggesting we use actually the scanner.
Okay.
Do we have the Pro in here on that scan?
Yeah.
Okay, perfect.
Yep.
So while you're doing that, then at least when they see it from here.
Okay.
So yeah, we'll just finish this and then go there.
Okay.
Yeah. Okay. Sorry, we don't prepare. We just improvise when we are in session. So it's gonna be like this. But so in Explorer is where you're summarizing everything. Now the patient can ask you questions. You can talk about if you missed anything. You can go back and make sure they're understanding everything. If you did not want to make your scan report in the beginning, you can make your scan report here. And then once I'm done with everything, that's when I go to this right here. You saw the in-phase visualization. You saw the Simulator Pro. That's what this is. So at the end, you just leave that on. And you say, do you have any questions? No, okay, I'm looking forward to seeing you at the next appointment. And you walk out. And before you walk out, they're saying, wait. How about this? When am I going to get my videos? When am I going to get my ortho? And if they don't ask, that's okay. You scan the patient at the next appointment again. That's when you use your time lapse again. That's where you use your occlusogram and the time lapse again. That is where you are giving them the education. You did not proceed with the treatment last time. This is what happened. Positive changes of the treatments that you did, you look good. Negative impacts of them saying no to treatment, you still look good. It's ultimately about us doing good dentistry and having healthier patients. So this is Align Oral Health Suite. It is a holistic visual assessment that lets you do minimally invasive dentistry, and I love it. Okay, so now, can everybody see it from here, or?
I've got it connected.
Oh, you got it connected? Okay. So I don't need this now.
Sweet.
All right, perfect. I'm going to actually borrow the chair. You don't mind? All right. So, you walk in, your hygienist has already scanned the patient, and at that point, you are actually basically here. Oh, sorry. Oh, it's still called ITero, please.
It is, yeah.
That's okay, no worries. Okay, but imagine this Align Oral Health Suite right here. And then this is the new screen that comes up. So remember where it was caries and gums and tooth wear? So now the headings are changed. So this is the new headings that they're still editing it, but most likely this seems to be the final version. All right, so now, Mr. So-and-so, how are you doing today? This is your scan. Let's just take a look what we found. All righty, we go to tooth health. And this is where you're going to use the NIRI and you're going to use the intraoral camera. So let's just say you can put both on, but I prefer doing one at a time. But let's just go. So now which patient is going to look at that and not ask you, what are those black things on my teeth, right? So you get going, you move from every single tooth, you tell your patients what they need to know, and you're discussing all your findings. Now let's just say these are crowns and they have leakage. You can talk about that when you are hovering over this area. So it's basically you're giving them the full view. And, oh, look at that. I'm not happy about that composite right there. You can talk to the patient about all that. And now let's just go to the second one. You can take screenshots here. So when we were talking about lab communication, not lab, insurance communication, this is where you can take your screenshots as well of NIRI. You can attach it. I think in Ontario, they're trying to get NIRI recognized equivalent of bite wings. We are not there yet, but for the time being, you can still take screenshots. Insurance won't accept it though, in place of x-rays. So this is where I would go. It doesn't take very long, but you're going to go over your. Now look at that area. Look at the distal of the 4-7. Look how easy it is to talk to the patient about that. Now this is where you can say, I can do that restoration. You're still going to have post-op sensitivity. How else would you explain to the patient? But if you didn't show this, would they understand what you're talking about? So this is the beauty of using the scan to make sure your patient owns their oral health condition. You didn't put that there, you're going to treat them. And this is the way to show them that. Alrighty,
Just
now,
a quick comment, that intraoral photo, you can see they did not use a very clean sleeve, and it drives me crazy. But that's the demo example I
I was
have.
thinking about
The picture is much nicer than that. We have other examples, but
especially when I was
Look how
there,
dirty
looking
that
at it,
is.
you know, like, what's going on? But, and when I was saying you can take, for the ITero screenshot, so okay, so let's just say you take that screenshot here, you go there, and now let's just say you want to draw things. You can say this tooth right here, this right here, you go to text, and you say 2-6 composite replacement, or whatever you want to say, and then you green tick right there. Now it's saved. Now it's uploaded onto your itero.com. It's always going to be there. Okay, then you have to keep the annotation. Don't discard it. I've kind of gotten distracted and just walked away. But yeah, you learn the hard way. Okay, then you go to Gum Health, and this is where you can go each arch or you can go together. Now that recession, look at that. Now you can take a screenshot again of that. How easy is that to show the patients what's going on? Patient comes in, you will have spec exams. I have sensitivity on the upper right. You are looking for probably, they're saying maybe I have a cavity, maybe I need a root canal, and sometimes it ends up after testing everything, it's actually that buccal recession or that buccal fraction. It is a lot easier to explain to the patients like this, because they'll say, no, but that's always been there, why is it sensitive? That's when you go to occlusal ground. Then you start talking about the occlusal wear and the occlusal interferences. But anyway, so this is where you can also talk about calculus. You can talk about recession. You can talk about staining. So once you've done your periodontal consultation or chat with the patient, now you go to bite. This is where, as I said before, I don't talk about malocclusion at this point. At this point, I'm just talking to them about their bite pressure. Where are, let's just say, okay, well, he doesn't have it. I was going to say deep bite and, narrow envelope of movement. He doesn't have it so much. But, you can talk about your occlusion. You can talk about rotated tooth, whatever you want to do. But this is where you're going to talk about your occlusion. Then you go to alignment. And this is where now you're going to tie that occlusion here. And this is, I go here, I usually like to go to the stone model. Okay, well, kind of class 2 tendency, but really class 1, just really tight bite. Okay, well, you have a little bit of posterior open bite happening here. Then you can take a look, are these teeth needing crowns, or is it that they are just like this? Are you going to do ortho based on that? Are you going to level that curve of speed? Whatever your treatment plan is, you can do it here. If you want to, in ortho, when I'm talking about ortho, what I really like again is my screenshot here. And then talking about, let's just say this patient possibly needs orthodontic surgery. You can start writing. Orthodontic surgery discussed, bicuspid extractions discussed, ortho referral discussed, patient wants to do motion appliance and Invisalign. Whatever you discuss, it's quickly you can write it here. It is a good habit to get into, because at the end of the day, when everybody's left and you're writing your chart notes, something to kind of remind you what all you talked about. And also, as you said, this PDF can be uploaded into your patient's chart. All right, so let's just discard that because we already told them. Okay, and then you can go to, one second actually, in alignment, let's go here. Our favorite thing, I don't know why I was going to forget about this. So remember when we talked about time lapse and when Mark and Natalie showed it to you? Now if you go here, when we are going on the older version, the viewer, there's nothing on the screen. It is a little bit of a distraction to the patient because the patient thinks we're done and we're not talking about anything else. We're talking about something really, really important. We're not done yet. This time lapse, I don't know why it's taking a little bit longer today.
Never works in conference rooms.
It usually works faster than this. But that's the other thing I've seen with 5D plus, the speed is way faster. You don't have to really wait for it to upload so much. And now you can talk about your time lapse. Here, you can actually, one second. Yeah, sorry, one second. Go here and then do it. This is what I actually wanted to show you guys. Okay, so now you can do time lapse like this. When we are talking about recession, we are talking about abfraction lesions or where it is okay to do one arch at a time or one tooth at a time with the magnification. When you are talking about changes, let's just say you did Invisalign for this patient and patient swears they wear retainers but they don't wear retainers, and you have the final scan from when you actually scan them for wearing retainers, and now they come in with 2 going to Vancouver and 1 going to Toronto. You scan that patient and you go right there. That's it. And now you can move these scans together or you can unlink them, but the whole model moves together in 3D, okay? So if it's linked, you can move them together. You can show the changes that have happened. You can unlink them, and then you can move one arch at a time. So this is time lapse of the whole mouth, okay? You can go one arch at a time here. You can still use your occlusogram. You can still use all the features, but now you have the capacity of using, this is where I like to use time lapse, not separately, because just in one, I can use time lapse for everything, okay? So this is Mark and my favorite thing, right? Alrighty, we are going to, okay, the green tick is not there, so
Yes,
this is
that
not
needs
the,
to be on a different one.
okay.
I just have these 2 examples here, Mary and I.
Oh yeah, we have it right there. Yeah. So then if that, the little flower thing, if it has a green tick, it means then you have the in-phase, actually the outcome pro. So then this is what shows up there. You can go in and you can just talk about
So
classic.
the demo mode doesn't, in your
Yeah.
normal one, you could move it around
Yeah.
freely. This one kind of just taps through,
Yeah.
unfortunately. So sorry about that. That's just
Oh,
what we
no,
get in
that's
here.
okay. But this is what I wanted to share with you guys because I'm super excited about it. And when all this came up, and I know that we want to introduce this to the dentists anyway, so we thought this would be an ideal time. You're a dentist, you can't do everything, even though we think we can do everything. You really have to rely on your team. And for a team member to agree to do scans and to talk to patients, it has to be an easy to use system. My team members, they compete with each other, who takes a minute to scan and who takes a minute and 10 seconds to scan. So if while they've come and told you, Dr. Randhawa, I'm ready for recall exam, and you go, okay, 5 minutes, if they haven't scanned yet, they can scan the patient, they can talk about, remember that sensitivity you were saying? I see something here, but let Dr. Randhawa come in and take a look at it. And when you come in, that wheel is on there. How easy it is. My hygienists actually even go a step further. They give me a nudge and they say, you know, they were talking about 1.7 and I saw something, but I would like you to take a look at it. Now that is planted in your head. You know, okay, I have to focus on that. But you can do things together better. So you have to get your team on board. Team will come on board if you have something that is very easy to use, very, the learning curve is very, very shallow. I don't even know if you can say that.
Yeah.
But yeah, and then it is about them believing that they're doing something good for the patient. If your hygienist or your assistant is using this and educating the patient, do you think that they are not doing their job? They're actually going beyond their job because they're educating their patients. And by the time you come in, your patient already knows there's 10 things that need to be taken care of, and you have just walked in as their savior, and you're going to tell them how you can save those or do those 10 things for you, right? So yes, this having digital technology and a good team is what makes me do what I do every single day, and I love doing it. And my team's here. Thank you guys for doing what you guys do for me every single day. Do not coach them. They're not looking for a job. Do not. And this is all I'm gonna have soon. So thank you guys.
Thank you.
So you just have to do the setup again.
Dr. Swap.
Swap.
That was awesome.
So good, right?
While I'm just getting my laptop set up, does anybody have any questions for maybe Natalie or Mark?
Or Dr. Randhawa.
Army.
Or Lovedeep, yeah.
Questions at all? I'm really excited about that, as Dr. Lovedeep talked on. I just think that people have a short attention span. I can't remember the statistic, but there's something about people will now abandon a website if it doesn't load within 3 seconds. Yep. Like you just click and refresh, and go, right? So before, we had most of these apps before, but it was kind of, okay, I'm gonna click on this, it's gonna load, show it. Okay, X out of that, click on this, load, you're like, it's nice weather out there, right? How do you take a lot of vacation? Like you're just filling the silence. Now it's just bam, 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 walk through. And I've talked to a couple doctors already who've utilized it in the LMR, and they say they like it for team and associates, right? The doctor who pays for the scanner, you paid for it, you're invested in it, you'll find a way to make it work so that you use your investment. But an associate might be a little bit more likely to be like, no, I'm just going to team on this. This is, you open it up and it's going to walk you through. Check the tooth health. Check the gum health. They keep changing the names. Check the bite, check the alignment, and then give the overview, right? It's just walk through. It's really user-friendly that way. Are we good? All right, we're set up.
2 seconds.
No questions? Really? We're good? Great.
So I brought a few stage props.
It's a great location. It is very convenient to get to.
I brought the latest wireless ITero scanner.
I hate that you bring that thing around.
So, Mark hooked up one of my teaching partner, Dr. Stephen Hill. What kind of system did he get?
He got the Plus series, the new one.
Yeah. So this is a decommissioned ITero scanner, and I use it for a stage prop now, but I just call it the wireless version.
Yeah. I had to remove the old scanner from his office for him, take it to the dump. It's 215 pounds.
So
Almost threw my back out.
as I go through my discussion tonight, if anybody has a good question, got a little stage prize here. So every one of the ladies in the room here love a nice lip gloss through the night. Okay? But only if you have a good question. Okay, so I want to quickly start off with talking about some of our history and our journey Dave and I have gone through in the dental lab business. And what we want to share with you, not only through my talk, but I'm sure you're going to have some questions for Dave and myself. Dave, stand up quickly, just so, okay. I always say he's the smart one, I'm the good looking one, or vice versa. But I want to start with the story first. In the mid-90s, when we really started our lab together as partners, we were on this quest and journey to create adjustment-free crown and bridge work. So my brother went to Dr. Dick Tucker's Gold Study Club once, and if anybody of you heard of Dr. Dick Tucker, he's the godfather of gold in dentistry. So, and Dave asked him, Dr. Tucker, what is the secret to having adjustment-free crown and bridge work? He says, you have to make sure that your materials are compatible with all the shrinkage and duplications throughout the whole process of making a crown, a bridge, or whatever. So we took that principle, and back in the day, we found and analyzed that Impergum, that tastes like a chemical factory in the mouth, shrank 0.05%. And our die stone, we had to come up with a die stone that expands 0.05% so that we can get a true duplication of the mouth. Does everybody track? Because we want margins, contacts, everything to come together. So now, when we had a tremendous amount of success over the years with Impergum and later on with honeycomb impression material. So now when the digital age comes into play, there's no shrinkage factor of impression material. Everything is a one-to-one scan. a 1-to-1 ratio of a good capture. And I say a good capture because what we went through in our journey with digital is we went for 2-3 decades of help Dave going into hundreds of offices, teaching staff and doctors to choreography how to get those crystal clear Dick Tucker type impressions. And now what we find that we're in the same evolution with digital, where we're going into offices and they're phoning us. How do I make sure I get a good scan? Because everybody knows garbage in, garbage out when you send something to a lab. And it's no different whether it's an impression material or if it's a digital scan. And folks, I'm going to share you some principles tonight that will prove, okay, and give you some tools that you can take back to the office that will literally bulletproof your records that you send out. And I don't care, I show these principles to anybody who, whatever scanner they have. And true as I stand here today, some scanners are garbage and some aren't, okay? Some are superior than most. But a lot of times, just like in the hands of an impression material, some people just fumble with trying to still pull up a nice impression, and we see that with a scanner too. So I'm going to show you some tips and tricks along the way, but I'm going to dive straight in. The reason why I'm going to dive into model analysis is because we live and die by the micron in the lab business, okay? Like literally, we have a doctor in Kelowna. He says, I want my bites for this case to 15 microns. I want this case to 40 and this one to 8 for whatever reason. So we have to verify that. We live and die by the micron. So like I said, I don't care how the scan or what scan sent into us, STL, apply file, whatever. I do know that most of the offices that we work with, more than 50% of our scans coming in are with an ITero. And so I don't know the reasons why, I just report back the facts that we see. Okay, so I'm gonna jump into model analysis. Okay, so let me just ask everybody here, coming back from a lab, any unit, what do you find is clinically acceptable on a margin or a contact? Shout out a number. How many microns? 50 or less. Because if anything is more than 50 microns out, we get a phone call. If it's a contact, if anything's more than 50 microns, we're getting a phone call. Hey, how come my contacts are tight? Okay, we're going to address that coming up. But anything 50 microns or less is clinically acceptable, and a lot of times, anything 15 or less is superior. So if we can nail that, all the better. So my buddy Steve, who my teaching partner, I did a test. I says, dude, you guys help me out. I want to do some analysis of different models, printed models, and impressions. So Steve graciously, we did just a single lower buy. So that's an ITero scan that he did. And so what I did was I took different models from different sources, printed models, milled models, stone models from a PVS, all from the same patient. And I poured out the cast, got printed models made, and we aligned them all. So this here is a third-party model here on the top left from some milling center in Quebec. This is an ITero model and a Siga. I forget what knockoff printer that was, and I forget what this. One of these is a carbon 3D model. And then I said, Steve, could you be so gracious to take a honeycomb stock tray, whatever garbage you got in the drawers, you know, for whatever making, you got, you know, Steve's always got leftover free stuff hanging around. And then take a honeycomb triple tray. So I poured up 3 casts, and then we scan the model, and then align it with the original intraoral scan. And then we do a 2D cross-section of the contacts, and we do the analysis. So honeycomb triple tray, okay? I don't know how many triple trays we get in. Sure as I stand here today, I sometimes close my eyes and wonder how accurate or inaccurate is this tray technique. But I'll show you on this instance with tray technique how important it is. Okay, so this is the intraoral scan. This is the stone model. We align them together. They align very nicely. So we take it in 3 shape, a 2D cross-section tool, and now I can measure and dial in what is the contact discrepancy between the scan and the stone model. What's that gap? Okay, so on the distal of the spine is 82 microns short. That is significant. Now on the molar, it's 81. It shows me that they're in the same ballpark, but what do you think is going to happen to that crown when it gets tried to be inserted? Frickin' lab. Tight contacts, okay? That is so significant with tray technique. Okay, ground contact. This is an extracted tooth somebody sent in for a shade one, so I have to take it for this. Okay, so 81 plus 82, that's 160 microns. If we, and our goalpost is to have, say, 40 or less. So I already know that this is a swearing session to get this crown to see. Okay, contacts are too wide. Prep is too short. Okay, stock tray. Actually, I want to go back to this. The prep is too short to the original scan. So think about this. When a patient, I was in an office last week, and they said, okay, clench into that triple tray. So the patient's just clenching in, and what does that do to the material, or the tray? The tray's gonna go like this a little bit. What happens when it comes out? It goes like this. So when a tray, this is like buccolingual, when the tray rebounds to its elastic point, the contacts do this, okay? So this is why I'm never a fan of triple tray. Okay, so let's go to the stock tray. Same case, same patient, same impression material. The only variable that's different is the tray. Look at this, let's analyze the data. 50 microns, right on the contact points. Gold standard for our everything. To me, that's immaculate description of what happens with tray technique. Now, before digital came along, the phone call went, doctor, could you please try a different tray technique? Oh, yeah, sure. And now, you know, when we're trusted, they engage. When we're not trusted, they try another lab. They throw the impression down another vending machine and see what comes up. That's just the reality of the lab business. So here's a common complaint that we get sometimes, and Mark has shared this to me before, and this is a reality with digital right now in the clinical end of restorative dentistry. So what happens is, we, and this is being completely transparent with our journey. We used to, when we started in the ITero digital game, we ordered all of our models from ITero. It was the only scanner on the market at that time. Then all the other scanners started coming on. We can't get the milled models. So because ITero was the gold standard with milled models, we thought, well, we have to find a milling center that'll mill models for us. So now we got a milling center milling models. And we got a third party, and we did the same analysis. And now all of a sudden, things aren't fitting. And now we're scratching our head, what's going on? And we lost a lot of business because of this. That's the reality of going through a growth curve. But the quality control question that I want everybody to absorb here is the lab scanning a model prior to designing a case? Because a lot of offices aren't aware that in the lab world, you have to pay, the gold standard right now in digital is designing direct to an intraoral scan. But if a lab does not have the license to import an intraoral scan into their software, their only option is to scan a model, a third-party model, or a printed model, a printed or milled. So they scan it with their scanner, and then they can design a case. We all see the flaw. Because now you're duplicating a flawed duplication. Instead of importing the original intraoral scan. And the reason why a lot of labs don't do it is because they don't want to pay the fee. So if you ever have an internal fitting problem, zirconia, Emax, PFM, whatever it may be, if it's an internal fit, it's because the model is probably being scanned after the fact. And then they rely on the accuracy of the model. And it's a big, big flaw that a lot of people aren't aware of. So Mark was sharing with me the journey. He says, oh, well, some ITero's not good for restorative, is what some labs are telling me. And it's bull, because all he has to ask is, anybody, are they scanning the model, the printed model, or are they designing direct to the intraoral scan? Problem solved. Big question if you ever run into that challenge. Okay, so have a look at this. So this third-party model, we scan it in. This data right here, the beige data at the top is the scan file. The black data here is the milled model. So if a crown's tried to seat here, is that going to seat down? Not in a million years. Is 50 microns too high? You'd have to put 100 microns or more of dye spacer on there and then scan it in. Nobody does that. It's digital. It's got to be perfect. So here on this case right here, on this ITero model, it's the opposite. I don't know what it is that they got an algorithm or something, but everything seems to be a half a millimeter or I'm sorry, a tenth or 50 to 100 microns higher. It's always going to see. Same case, different milled model. Very, very important. So that's why it proved to us that when we got ITero models at the beginning of our journey, before we got into the printing game, that we would take a milled ITero model, scan it in, and we still had superior fits. Does everybody track with me on that? It's a really, really important principle if you're going into the digital game. Okay, this loose contact. Follow the data. Like I was showing, we have the ability to cross-section two files together, analyze. We can problem solve where the flaw is. So because that's one of the biggest things in dentistry is if we don't know where the problem is, we can't come up with a solution. We're throwing mud against the wall and seeing what sticks. So like Mark was saying, we'll do analysis on cases, but you have to follow the data. Digital gives you the data. It's awesome. Okay, so doctor complains that the mesial contact here is wide open by a country mile and literally accuses us of gross incompetence. So I'm like, okay, now I got my back up a little bit because, you know, I've made mistakes in dentistry before, but gross incompetence ain't one of them. Okay, so let's see. It's no point in, there's no audio on this, Mark with a C. Okay, so I sent this video to the doctor. So he took a pickup impression here with the crown in place. So I took that stone model, I scanned it in, aligned it with the original ITero scan. So it's a half a millimeter out of whack here from where we designed the crown. So my spider sense is tingling already at this point. And I go and I do my analysis. And I do a 2D cross-section on this contact right here. The actual stone model without the crown on is 26 microns accurate to the intraoral scan. I'm thinking, what's going on? The contact is accurate. Okay, now my spider sense is tingling even more. What's going on with the prep? Even though we waxed out the crown, what's going on here? Hi, Nate. Ty brought me your case for Leo and the frustration of the contact. Sorry for the frustration. After my analysis of the records, I found that from the first scan to the second and then to the pickup impression, you can see that the prep tooth has moved distally 450 microns. It's half a millimeter. I don't know why this is moving. Maybe you have some clinical insights. We'll snug up the contact to the pickup model. After analyzing the pickup model to the original scan, it's very accurate to 26 microns. So I sent him this. Any questions, please shoot me a call. Sounds good. Teeth move. Where's the gross incompetence? Okay, so my point here, going through this exercise, and I've shared this with Mark, he's thrown it out there. If anybody has issues with their scans and you want to find out the true reason and the why, we always search for the why of a problem. If it's open contacts, margins, fits, we can absolutely do a complete analysis of your records so that you can find out what's going on. It doesn't matter what scanner you have, it doesn't matter. We always want to get to the why. Okay, here's one, flawed scan of contacts. So we'll just see how this video unfolds. I think it started, yeah, I should have sped this up a little bit. So I did the same type of analysis. We got an intraoral scan, and then we have it's very common, a PVS impression the doctor took. We draw a line through the contacts, and I just start playing the movie with the scroller to see what's going on here. So I see this bump. What could that be? Any suspicions? Something is sitting on the surface of that contact that shouldn't be there. Sorry, I couldn't hear you, Lovedeep.
She said, issue was a retraction cord?
I don't know, but it showed up. But here's what I do know.
She's trying to win the glow-in-the-dark
I know.
gloss.
Okay, well, she sent us a couple arches. She might get one anyhow, just for showing up. So here's what I do know happens in the mouth, and I'll touch on it more later on. But you think about this. A scanner is going to pick up any data, the outermost surface, if it's hard data, hard tissue. A PVS impression here, when it gets seated into the mouth, the material actually acts like a squeegee over every smooth surface. My suspicion is that there is some sort of crown matter, tooth matter, something that was on the contact that the scanner picked up. That's my only suspicion. Because when this impression was taken to try and solve it, for us to analyze it, that's the only thing that I could see action-wise that was different. Okay, so if anybody would like a case analysis protocol, we just ask for upper and lower scan of whatever the case may be, stock tray impression, and if you really want to nail down what's going on so that you can fine-tune and triage, move forward, that's what you want to send us. And then we'll just do a little report. I'll shoot you a little video. We figure it out. But that's the only way you can do it. That's our case analysis protocol. It's an impression and a scan, and this is pretty much what we're going to figure out. If you truly want to figure out, because here's the reality too, everyone. Okay, doctor invests in a scanner system. And a lot of times they want to delegate the pre-op scan or they just want to scan the prep. And they delegate it off. So a lot of times the CDA may be new to scanning, not familiar with that scanner, staff turnover, all the things these guys are training around. And if you want to figure out what is going on, you have to get the data. And this is the data that we have to bulletproof and find out for you. Okay, so here's the 5 areas that we evaluate when scans come in. Clarity of the teeth. Mark was showing some of the scans there with a dirty tip sleeve on the scanner, and that's going to obscure clarity of the teeth. Quantity of the teeth for each case. Clarity of margins. It's huge. Clarity of contacts, like we were just covering. Accuracy of the bite. This one is actually one of the easiest to do, but the most often overlooked. So let's talk about clarity of the teeth. This is what I learned when Mark said, hey, you got to check out this program down in Raleigh, North Carolina. Is it Raleigh, North Carolina? Yeah. So I go down there, and they're talking about how to get the best accurate scans. So literally I'm pulling back a few pearls here that apply to not just an ITero scanning system, but any scanner. So this is a big one, and it makes so much sense to me, because just like that contact that had some crown matter on it, dry the surface with a 2x2 gauze. Do not air dry. Don't do the suck technique, to try and clear the teeth. Actually wipe the teeth down with a 2x2 gauze, because now we're going to be, any surface that's going to be scanned, any crown matter or from any surgical procedure is going to be physically wiped away and dry all at the same time.
Especially the contacts.
Especially the contacts and the prep. And, I was in an office a week or so ago, and I recommended that, and the doctor says, well, I got fat finger syndrome.
You gotta see the A's.
So he pulls out the tweezers with the 2x2 and starts mopping around the teeth. It's like, my gosh. Okay, so like prep number 7, but can't wipe the teeth down with a 2x2. Okay, so, and this is another big one that we can tell by looking at scans. Hold the scanner tip. That's why I brought my wireless scanner here. Always make sure that the tip is 90 degrees to whatever surface. If you're just trying to get a buccal margin by going like this and a little bit, you're not going to get clarity. It's like trying to look down the end of a building and try and look through the window. It's just not going to, you're not allowing the device to do its job. So 90 degrees towards any surface. Okay, scan pattern. Mark was, did you show a scan pattern earlier?
No, I didn't.
No, I didn't. Okay, scan pattern. My brother was in an office not too long ago before his vacation. And the CDA was in there going like this, trying to capture data. And it's like, the device is designed to cache data in a nice linear fluid motion, not jumping around like a jackrabbit in the mouth. That's how it's designed. So that's a very, very important principle. Otherwise, you're not going to get proper stitching of the data. All right. Do not dry the teeth with air. It only blows saliva into other areas. So we want to get rid of it. Okay. Dry surface. Do not air dry. Just for people that don't know how to wipe down teeth with a 2x2 gauze from my skull.
Got it.
Okay, 90 degrees to the surface. Very, very important. We all know trying to get these angles here, contacts or the size of the prep, we know it's difficult. Rotation. These two are probably the best to teach you and coach you how to get those tough areas. "90 towards," yeah, this is what they were saying. Renee said that. Just like a toothbrush. Now, I put this slide online once, and this lady roasted me. She's like, "You're not supposed to brush teeth at 90 degrees. It's supposed to be at 45 or whatever."
Gross incompetence.
It's like, lady, it's a word picture on how to scan teeth. I'm not trying to teach you how to brush teeth. scan pattern. So this is the scan pattern.
That was,
Okay, very important. Use your posterior reference, your most posterior tooth as a reference point, and go linearly up and around the arch. And then back. Not jumping around like a jackrabbit like this slide here. And I'm not going to go into the whole research study. We cover that in more detail when we do a full course. Okay, so let's look at quantity of teeth for each case. This is a big one. And I want to share with everybody the principle that the trap that I see everybody jump into when they go into the digital game. And it's called the digital trap. Because a lot of times, anybody in digital dentistry, they have this expectation that just because it's digital, it's always going to be perfect. And it's so far from the truth. There has to be an employment of technique, and we still have to apply all of our dental principles. I don't care if you're taking a scan for a night guard, or you're taking a scan for a single crown or an arch. We still have to think our dental and not just apply, and trust digital is going to be perfect. So, in a general sense, we always want to make sure there's for a standard quadrant case, we always want to make sure there's a posterior stop and an anterior stop if we're going to capture the bite. Does that make sense to everybody? Okay. This is probably one of the biggest mistakes we see in occlusion when you're doing digital dentistry. Oh, well, we do a bite scan, patient comes into play, and we have maybe a canine as a positive stop. Well, see how far that goes. And, well, look, we gave him one tooth. How on earth do we even get any sort of function dialed in here with one posterior tooth? If you're doing any free end case, even if it's a single molar back here, let alone a 3-unit bridge, just scan the whole arch. Like Natalie was saying, it takes what, 120 seconds? Okay, it's not a time consumer. So, but the accuracy factor goes to the moon. So when you're setting up cases, always anything 2 units with a posterior positive stop, you can do a quadrant scan. But if you have no positive stop back here on the last tooth, do the whole arch. It's very, very important. Okay.
Make sure the patient's clenching for the bites.
It's coming. And anteriors, oh, it kills me when we get scans up to here and beautiful margins, the whole thing. We can't dial in any function, no centric. We need the back teeth. God put all these teeth back here for function. We want to use that data. Data's king. And another one, and I'll show you later on why it's so important. But as a habit, always just scan the palate. If you're going to scan for, like, especially a wax up for any type of anterior work, arch work, or anything, always scan the palate. And it's so, so critical when you're placing a putty matrix for temps, because everything is going to rely on your positive stop. Very, very important. And if you're doing any pre-op scan for wax ups and so on, turn off the AI, because we want to have scans all the way into the vestibular areas as far as you can go, the palate. We don't want the AI to stop at, 4 or 5 millimeters from the CEJ? Is that where it goes? We need that, especially if you're doing a lower wax up. We need the border areas all the way down, because that's the positive stop for a putty matrix. Yes,
I just want to ask a question on that. When we're doing that, turn off the AI. When is it too much data for you? Like in that case, if you're doing
as long as it's accurate.
Okay, so it's not like, I'm always afraid because I'm like, oh, don't overscan. I'm like, am I going to send you this massive file that is?
Well, as long as you're not overscanning.
Yeah, but as long as you're just getting everything.
Oh yeah,
Okay,
like
so that's
right down to the borders.
Beautiful.
That would be awesome, especially for a lower wax up.
Yeah.
Because that's your positive stop when the provisional putty tray goes in. It's got to go onto something. But when we get scans where it stops right here, and there's no palate, the only positive stop, if this was an arch, for like prepping an arch, a full wax up, there's This is it for the positive stuff. So now your whole provisional tray can be compromised with seating because there's no stability. Very, very important when you're planning for big treatments.
Light up lip gloss.
Pardon me?
Light up lip gloss. Oh, yeah.
Was it
You're
Oh,
being
yeah. Sure.
You're being
I
real
don't know the
sticky with
question.
those. David's got like 2 of them already.
Yes.
Okay,
Oh, this is the coolest thing ever. I'm laughing.
clarity of margins. Okay, good tissue retraction with a basic 2-chord technique. I'll be showing you a couple slides from my buddy Steve. Same thing, clean surface. Keep the scanner tip 90 degrees to the surface of scanning. If your margins are looking like this, probably 90-degree angle is going to be an issue. You gotta roll that scanner tip down so it captures this way, not that way. Okay, this is actually a really cool slide because my buddy Steve Hill created it. Okay, so 2-chord technique, and what he does is basically pulls the 1 chord right when he scans. And there's a really, really important principle here in restorative, and I was in 2 offices in the last 2 weeks that violated this principle. And that was, you have to get the prep scan. By the time you pull the cord, unless your margins are above the tissue, but if your margin is sub G and you pull the cord, you got to get that prep scan within 10 seconds. Because otherwise the tissue is going to start to do this. And then you've got to rescan. So very, very important. Margin placement and also the timing, choreography. It's no different than Dave would go into an office and say, okay, doc, don't shoot your light body until the assistant has the tray loaded. Then shoot your light body. Well, why? Because if you shoot it too quick, it's going to preset. By the time the heavy body comes in, you're going to have a drag. Same thing in digital. When you're pulling a cord, you have to have your choreography ready to go so that that tissue doesn't fold in on you and distort the skin. Okay?
I have seen Steve Hill do his preps before and take his scans. He has some of the most beautiful work there is, the most beautiful scans there is, and I've seen him, he'll go and he'll pack his cord and all that, and he'll actually practice taking that out and getting onto the middle of that prep 2-3 times before he actually takes the scan. Like, it's a little bit, overkill, but James, does he have any remakes or any issues at all? I mean, his work is
No, it's flawless.
gorgeous, right? It's take the time with digital, follow these steps, it will be
So this is a
flawless.
good stock slide from ITero, just on the timing. If you wait too long, messes are going to happen.
James, there's one more
I'm so
question.
sorry, I keep asking questions.
You want all that lip gloss.
I'm so
don't you?
sorry. That's exactly. How do you feel about something like Traxidin conjugation with the cord, or are you like, what's like, there's that option as well too, for moving the gingiva away, or are we like,
Well, usually cord is to control the site and
Yeah.
expose the margin, whether
How
you
do
do
we feel
PBS or scan.
what do we think about something using something like Traxidin instead?
You mean
Or
with the putty stuff?
Yeah, that stuff. That's
Oh, I don't care.
like in
Use
your
a coat
experience,
hanger
just
to pull it
yeah.
back. I don't care.
No,
As
you
long
like,
as you
does
can see it.
Does it make any difference at all in the final scan?
See, the nice thing when the putties, everybody knows the putty we're talking about, the Expasil and
Yeah,
all that sort of
Expasil,
stuff.
Traxidin,
Okay, there's
yeah.
many different brands now. I don't know them all.
I know.
When that stuff first came out, we had a doctor in Port Grey that was using it. And all of a sudden he's going, oh man, honeycomb's not setting up, It's like, what do you mean? Like, it's flawless, right? Well, if the prep isn't washed completely with the residue when you pull putty stuff off, it can retard the setting of your light body. It won't set, it'll come off like a taffy piece of goo. Okay, so then, now you can still use all that stuff, and you don't have to worry about PBS being distorted because you're doing an optical scan. So you can work with that. The whole point is, can the scanner see it? And that's why in all reality, if somebody has a deep distal sub-G margin that's down at the bottom of a canyon, pull out the PBS. If the scanner can't see it, it's not going to record it. It's as simple as that. And those are just some of the realities in restorative. So once again, 90 degrees to the surface. Did you want another lip gloss?
No, thank you. I did just ask you a
I thought
question.
you were stocking up for your friends or something.
I promise.
Okay, I got a slide in here in duplicate. I got to refine it. So once again, this is rescanned at the 90-degree angle. So if we see fuzzy margins like this, it's a flag. And that's something that you guys can all see right on the screen before you press go. Okay, clarity of contacts. We kind of touched on this a little bit earlier. Clean it with 2x2, not with air or water rinse. Once again, 2x2. Set the occlusal surface. Okay, I got some good stuff coming. I don't want to waste any time. Okay, accuracy of the bite scan. This is a big one. Big one. Now, in all fairness, it's easy for us on the lab side to go, oh, lousy bite. Whether it's a PBS bite or a bite scan. Oh man, why do they do this? One of the things we learned from John Martin way back at the beginning of the ITero days is he's like, we're teaching everybody that before you take your bite scan, have the patient come into centric, have them clench, and then record your bite scan. I go, Johnny, why is that? He's like, James, think about it. A patient's frozen, and you got a couple molars prepped back there, and you say, okay, put your teeth together, they're frozen. They don't know exactly where their centric is supposed to be all the time. So you have to, as a clinician, help them get into it, verify it's there, but then you got to keep them there because they got this wand that's going in, and as soon as the wand goes, what's the body's natural reaction? To do this. So we can see so many times scans, the bite scans that are flawed when they come in. So when that happens, we print the models, we actually hand articulate them so that they are in MIP, and then we scan that, and then we design the crown to it. Yes, Lovedeep.
So if we are doing the restorative in the MIP,
Yeah.
what do you think if we pre-treatment scan the patient before we even anesthetize the patient or prep the teeth? We take the scan to the upper lower arches and we scan the bite as well. And then afterwards, once we prep, all we have to do is just scan the preps and scan the proximal contacts.
However you achieve your bite scan that you would like us to, build a crown to or an art bridge, whatever, restore to, that's to us is the gold standard. So what I would always say and recommend, if you're going to be prepping 2 molars, anything in the posterior, equilibrate the bite to where you want the finish point to be. Then do your pre-scan, bite scan, scan the prep, however. And having said that, I had this discussion with Mark once. He's like, well, we usually scan the prep first and then do the... Okay, that's fine. I don't know all the procedures of all the different scanners and the software. I don't know all that. All I'm saying, in a perfect world. Oh, yeah. I was going to Tom Brady that to her, Okay, so that's always the gold standard for us, because nothing is more unpredictable than if we get a couple molars prepped, there's 1 tooth in occlusion, and we have no clue if that's the proper equilibration for the final case. So once again, clench, and then we want to fight the patient's neurology to resist when a wand goes into the mouth. Okay, bite scan. Once again, clench. Now, when we're talking about guards, airway appliances, orthotics, who here is scanning for guards? Oh. Okay, Dave, you gotta take a picture of all the hands up because they're gonna need split bites. Okay, so one of the most ingenious things my brother and I came up with, not last winter, the winter before, when we were driving up the Coquihalla to go snowmobiling. It was driving us nuts that we would get night guard scans in complete MIP. So, the reason why that is such a challenge for any lab is because patient needs a minimum of 2 millimeters on the last molar. If we take the software and just arbitrarily hinge it open, I can just about guarantee that whoever's placed in that guard and equilibrated into place is gonna, if we make a 2 millimeter guard, they're probably gonna equilibrate a millimeter away, and within a month or two, the patient's gonna be back and they're gonna say, oh man, you gave me a lousy guard, the thing's split in two, you know? So what we did was, we thought, okay, we have to equip an office to come up with a pre-open bite that duplicates a patient's natural hinge and translation, no matter where their bite is. So we thought, okay, so we came up with this split bite jig, and we had a tremendous amount of success because now we're getting pre-open bites coming in. What's the challenge with that? The challenge came when we designed this split bite jig. We thought, okay, we got a 4 millimeter opening here. We're going to have approximately a 2 to 3 millimeter opening in the back. But the challenge came in when a patient had a 4 or 5 millimeter overbite. Now we put a 4 millimeter opening. Now we cranked them open 8 millimeters. And now when we get the case of scans in, we got to close them down. Now we got the same problem, only we're going the other direction. So my spider sense was tingling, and we had to come up with something. So anyhow, this is a case of a classic situation. So when we get cases like this in, we're just sending split bite jigs back to the office. Okay. So while Dave was in Europe on vacation, I came up with this idea, and I thought, okay, instead of dialing in the thickness of a night guard from the anterior, let's dial it in from the posterior. So this is how we do it now. We take this split bite jig here, put a little dab of bite rag around it, instruct the patient to open. Patient closes right on the last molar. Okay. Now, you can even pull this little jig back a little bit so that the wand can get to that side to do the bite scan. Okay. Oh, there's my video. I'll just let it play as I talk. So now we have a perfect 2 to 3 millimeter opening in the back.
It's not 3.
It depends on the angle of the teeth, right? Because if you have a fossa that's about a millimeter from the buccal tips, right? So it could be, depending on the angle of the fossa, it could be 2 to 3 millimeters thick in the back, which is totally acceptable. And now, just with the skull demonstration, now with the 2 millimeter in the back, we got a 4 millimeter opening in the front, which is no big deal. Patient can handle that all day long. Okay, so 5 key areas to evaluate for accuracy: clarity of teeth, quantity, clarity of the margins, the contacts, accuracy of the bite. These are the 5 things that is the most critical thing when you're sending scans into the lab. So we're going to evaluate some scans. Let's have a look at this. Video, okay. So in your own mind, how's the clarity of the teeth? How's the quantity of the teeth for each case? We'll have a look at the margins and the clarity of contacts. I would say this is somewhere close to a dog's breakfast to make a crown on. Because there's absolutely no clarity around here on the margins. The bite was not accurate at all. The clarity of the teeth, well, there's missing data all over the place. So we did require a rescan on that one. Okay. Sorry?
Non-beef prep?
Well, I don't know what the prep looked like. I don't judge preps. I'm just judging quality of scans here.
And how fast do you guys, let's say that we do the prep today, do you answer tomorrow? Do you wait for 2-3 days?
Well, usually when the scan hits the lab, we're triaging cases that day.
Okay.
And usually our CAD techs, if something's up, like me, Dave, Ty, Kurt, we're flagged. Say, hey, we got to put a call in here. And a lot of times in a situation like that, we'll just have a look at the scan, or we'll put it into our 3Shape software, and we'll just take a little 1-minute video, and we'll just text it to the doc. We'll just say, hey, we see something up here. What did you see on your end? Do you see something that we don't? I don't know. We've seen all sorts of things, right?
And that's the advantage of digital.
How's the clarity of that prep there, right?
Call it in.
Yeah, call it.
Yeah, just
And
call
do you
it in.
normally get photos?
Pardon me, dear?
Do you normally get photos for the patients?
Uh,
The color,
Well, we never get photos for a case like this.
No, I mean in general, like say for the interior.
For dentures?
No, whether for dentures, whatever, anything.
Anteriors.
Oh, anteriors. Oh, yeah. Photos are all usually taken with a digital SLR. And then our email address is photos@oceanceramics.com. And that's where any photos with doctor or patient name, it just goes right into our patient library. So, and every ceramist and everybody has an iPad. So whenever we design a case, or build a case, they're working off of those photos. Yeah, the photography is very streamlined. But yeah, this is definitely a request for a rescan. Do they need to reprep? I don't know, I can't judge that. But once again, clarity of teeth, quantity, all these things. This was I believe this was a good one. Clarity, I should have speed this up here a little bit. The only thing I would have critiqued here is a full arch because it's a last molar. But I think we were making no, we weren't making a gold crown. Oh, it was opposing a gold crown. So once again, I just evaluate these 5 things here for each of these scans. This is a good one. Clarity of teeth was awesome. Full arch scans, margins were great. Everything was awesome. Now, I think I remember at the end of this video, there was only one thing I would have probably recommended on this case here, and that was, look at the margins, it's awesome. Clarity is awesome on the margins. Contacts look nice.
Some scanners will clean up the file once you hit send, and the lab will receive a different looking image than you see on your scanner. The ITero is not that way. You see, whatever you see is what the lab sees.
So the only critique I would have said here is, on these last molars here, it's looking a little bit heavy on the bite. Maybe an equilibration there before sending it off. That would be the only critique. Is that going to make or break the case? Probably not, but that's just not. So I want to finish off by showing a little bit of application of the data that we work with. So this is a case done by Dr. Heidi North in Whistler, at Whistler Dental. Patient Maggie here is the biggest realtor in all of Whistler. She has probably the biggest diamond I've ever seen known to man on her finger. But she wanted a full smile. I think we did her lower arch eventually too. So I happened to be in the office and I took some photos of her and had a discussion. And I says, Maggie, you know, there's a couple things I see about your teeth. She's in temps here. She wanted everything whiter than her eyeballs. And I says, I think they're a little bit long. She says, I agree. So then I says, you know, Maggie, you have such a wide smile zone. What do you think about treating these posterior molars, these molars in the back here, and really fill out your smile? She goes, and I showed her this image because I loaded the photos immediately up on the doctor's screen in the operatory. She goes, yeah, let's do it. That simple. So Dr. Heidi was thrilled because there was like 4 more units into the treatment plan. But I says, okay, Heidi, we're going to take some scans and the photographs. Now with the facial photos, we're going to apply it to the digital records, confirm the shade. She wanted 010, and that's about as white as we can possibly go. So we took her provisional scans and imported it. Once again, they didn't give me the palatal data, but we were already in preps, so it didn't matter. But if this was a situation where we're going to be seating some, Lexatemp provisionals, this could compromise the seating of the putty tray. Okay. So anyhow, we're able to import the data and get it aligned. And there we go. So now we took the provisionals there. We actually just took everything and just shortened it right here, approximately 0.5 millimeter. So we took it from, you can see from this left image here, and then we just took everything right off the table, the horizontal table. And I still haven't got the final photos. She ended up selecting the natural smile design. If you want to see a great tool on our website for communicating to patients smile designs, to really have them make a pick, we have all these smile designs, and you just scroll through, and the only thing that changes is the 6 anteriors. And you can really then say, okay, give me a natural, an aggressive, an oval, whatever it may be. So literally within a week after her case went in, she changed her website fully. So that's the only after photo I got from her. So, but this is a great application of just taking a simple provisional scan on how we can integrate it into an arch. But I can't stress enough the getting palettes when you're doing those. So I hope everybody got a few tips and tricks from the lab end of things. Dave is in the back. He's got a fistful of split bites. If anybody wants a split bite to take home and scan some guards, we brought a good handful. And the biggest thing, everybody, I want to stress, that this is what we see from the lab end. And this is one of the biggest concerns with any scanner that every doctor says is, how do I get my staff to use it more? And I can't stress enough, get them to practice. Practice on each other. Take a bite scan. Take a scan for fun, like where Natalie was saying people are having competitions. I don't know. Put a bottle of Prosecco on the table and say, hey, the fastest scanner, the best scan, go wins a prize. I don't know. Get the people getting familiar with it. If they're not familiar with it, they're not going to make a mistake and correct it. It's a tool that everybody has to practice with. It's not going to do it for you. You have to do it for it. Okay? All right, everybody. That's all I have to share with you tonight.
So make sure that you have signed the sign-in sheet. If you want to receive your CE, you should be receiving it in a day or 2. We're going to send them to you or email them to you. We have Monday night's webinar with Dr. Randhawa in Vancouver. Thank you for coming. If you want to come and chat, play with the ITero, come and see us. If not, good night, everybody. Have a good sleep. Thank you.